much for allowing us the opportunity to share the work that we've been doing in Lisburn over the last couple of years, exploring a place-based integrated approach to understanding and addressing health inequalities. Just to acknowledge also on the slide that Joanne Vance, who is the co-chair of the steering group and has helped enormously in this work. So it's just to acknowledge Joanne. Okay, so Lisburn, for some of you who aren't familiar with Northern Ireland, is in the southeast of it's County Antrim in Northern Ireland, and Lisburn itself is quite an affluent city, considered quite one of the most affluent within the local authorities within the Northern Ireland. But within that, it masks pockets of deprivation. So we have communities within Lisburn that are within the 20% most deprived, and quite often overlooked then in terms of resourcing through local government and other structures. COVID, as has been mentioned by the previous speakers, identified quite significant inequalities within Lisburn, and really for some of us put names and faces to some of the statistics that we were familiar with. And really, as the pandemic kind of rolled out, we identified the widening of inequalities that we were seeing within the city, but we really didn't know enough about what the inequalities were. So we needed to understand what the inequalities were and what that looked like and what that felt like to the people who were living, working and providing services within the city. So we focused in on the 5 district electoral areas within Lisburn City, and we built upon the leadership within the Integrated Care Partnership for Lisburn and formed a steering group and had a call to action, which really helped us to see whether we were talking to ourselves or whether there's enough interest across the community and within the partnership to see whether we do something different to inform our understanding of health inequalities. So what we have done is develop a locality health profile, and you'll see on the slide some of the processes that we engaged in order to inform our health profile, and Lisa will take you through some of our findings. We really applied the 3-legged stool, I can never say that word, 3-legged stool approach to gathering the data. And that was really, really important. Coming from a community perspective, it's really important for us to not just gather the data and some of the evidence around what's working within our communities, what the issues are, what the inequalities are, looking at the statistics, be that regional and local and as local as we can find it, but also to take account of the lived experience. It was so important for us to understand what it felt like to experience inequalities from a professional providing services in the community and for people who were actually living with that experience. So you'll see across the slide that we engaged in a number of different forums to be able to gather data, including our ECHO community of practice. And that process just continually allowed us to check back and forward with the information that we were gathering to ensure that it was making sense to the people who were part of our network. And it culminated in our knowledge exchange, where we shared with them the population health profile to check whether we were on the right page in terms of understanding the level of inequality within the city and what the data was telling us and what that felt like for people who were experiencing that. I'll pass you over to Lisa.
Thanks, Gillian. Thanks, everyone. I'm going to draw out just some of the key points and challenges from what we found and how we drew the strands together. So there's some caveats around the data. Good data is complete, accurate, relevant, accessible and timely. And one of our main issues was timeliness. The census is the most comprehensive source, but it's only every 10 years. And we were looking just before the 2021 census results. Data was reported at different levels. We were looking at these 5 DEAs, but that was reported across Northern Ireland or right down to ward level. And we were looking, we had to decide whether a particular measure applied to our population and how useful it was as a tool to drive action. We triangulated different types of data from different sources, but throughout there was a constant ebb and flow of refining questions and ideas because we were wanting to shape a common understanding. As Gillian says, broadly, Lisburn's very affluent, but we wanted to zoom in and see the detail. It has a rapidly growing population, more so than Northern Ireland as a whole. There's fewer young people, more older people, and a growing number born outside the UK and Ireland. We found wide variation in age, deprivation, and not least geography, with areas of inner city deprivation, but also large rural areas with poor quality housing, limited local services, and poor transport. Just under 1 in 7 of the population are income deprived, compared with Northern Ireland average of 1 in 4, but there were pockets of inequality. Some of the trends we found were in keeping with Northern Ireland overall, but some were unexpected, like falling drug-related deaths in some deprived areas. And most of all, there were the relationships between the numbers, the stories, and the people. So between different statistics, and crucially between the people, the collaboration was so important. And often we heard, oh, we have this data, this report, but we didn't think anybody else would be interested. So really what we found was that what you find depends on what you look for. Is it widening gaps or an overall picture or variation, who you ask, and what has been measured. So these are just a few of the data sources. We use publicly available data, but even then it was quite overwhelming. So we had to focus and ask who has what could be useful, and where could we make a difference. Through our engagements, we focused on what mattered most to people. These were the issues that kept coming up, but suffused through everything was the cost of living crisis and the continuing ripple effects of the pandemic. Everything's connected. Picture it like tangled strands of thread, and you need people to untangle it and weave it together into a picture like this tapestry, but even then it's incomplete. So we were always sense checking. Is that what it feels like for you, looks like in your service? For the workshop at the end, we chose topics for which we had both statistical and lived experience data to cross-check, but we had looked at many others. In terms of physical health, most people reported good health, but the area with the highest levels of self-reported bad health had over 3 times the rate of the lowest. The highest rates of long-term illness were twice the lowest. The highest age standardized death rates were almost twice the lowest. There were big differences in COVID deaths, marked deprivation gap for cancer, smoking-related deaths, and smoking and pregnancy. Think about the geography, the access to services. 12 of 15 pharmacies were in and around Lisburn city centre. 2 rural GP practices had no nearby pharmacy. Around mental health, we have some statistics, but we know it's not all visible. Substantial unmet need. Lisburn had a lower rate of self-harm admissions than Northern Ireland, but the deprivation gap was widening. Mood and anxiety prescriptions were rising and much higher in the city centre. And just to note, Lisburn also straddles 2 trusts. People might access services in a different trust from where they live. We looked at education and employment, obviously interrelated. We measure things that are reported, and there was a wide variation in school attendance, achievement, and eventual employment. There was a much greater proportion of newcomer pupils in one area. In terms of employment and the long-term health conditions that I mentioned, in one area, 1 in 8 were economically inactive due to sickness. We think about intergenerational poverty, and in some areas, almost 1 in 4 people had never worked, and this was twice the average. And also around 1 in 8 of the Lisburn population provided unpaid care. For housing, the key factors were tenure, quality, heating, and occupancy. Over 1 in 6 homes in one area was in disrepair. The highest levels of social renting was 1 in 3 households, and that was twice the average. There's an energy crisis, and home heating accounts for 14% of all greenhouse gas emissions, but more than 1 in 5 homes overall. And in some areas, almost a third didn't have a modern boiler or proper insulation and double glazing. WHO have declared loneliness a global public health concern, and almost 1 in 7 households in one area consist of a single person over 65. Drugs and alcohol showed some of the biggest inequality across Lisburn, as they do in Northern Ireland, and one of our community practice sessions focused on that topic. We found a sharp decline in alcohol admissions in one area, increasing drug admissions in a couple of areas, although overall falling. And drug-related deaths were falling in some of the deprived areas, although rising across Lisburn generally, and this led to some conversations about good ongoing work in that area. And that session was a really good example of how we were able to draw the numbers and the lived experience together to help people make sense of it all. So I'll hand you back to Gillian now just to finish up.
Okay, so I hope that's given you a really good oversight of what we now understand about inequalities within Lisburn. And just in terms of what we learned, I'll be very, very brief with this. You know, this has been a process. So agreeing and developing our shared values and our understanding of what we mean when we're talking about inequalities was a process and a learning curve for a lot of us within the group. But importantly, it was about what are we looking for? And Lisa's given you an overview about the data, and particularly about how we can look at the data at a very local level, but also how we can look at the data across different population groups or other sections within the community. What it feels like to experience inequality is really, really important to us. So who we're asking and including that lived experience, and given that lived experience equal priority was really, really important. But so too was the role of the community of practice to give those professionals and service providers within the Lisburn area an opportunity to have a safe space to talk about some of the challenges they're experiencing, what inequalities looks like when they're providing a service. And one of the things that I thought was really important that came up was people were saying routinely that people who are experiencing inequalities quite often don't know that they're experiencing inequality. So we heard earlier about power and you know, the importance of that, and that was an important aspect for us. But also many aspects of the current system, the quote on the right hand side there, are failing individuals and increasing rather than reducing inequalities. We have a collective responsibility to do something about that, and we heard that quite consistently at the Project Echo. So just to conclude, what we should do now, I mean, this piece of work wasn't new money, wasn't a new project. It was about a group of committed professionals across and communities across Lisburn saying, let's think about how we do better with what we have, or how we understand more with what we have. So the leadership from within the community, the committed partnerships, and that expertise that Lisa and other colleagues have provided, that trio is really, really important to making this work. But what also is important is having some kind of governance structure. This work was led by the ICP, which finished in March last year. So we have looked to embed this work within community planning or other strategic frameworks within the local Lisburn Castlereagh City Council area and within the Trust and within other statutory partners to give this a home within those kind of strategic structures. But equally with doing that, we have produced a lot of data. We now have a better understanding of what inequalities looks like and feels like across our city. We need to do something with that. So there's a direction there, or a kind of a focus there for all those partners to use this information as evidence-based informed planning, decision-making, resourcing and allocating all their services and strategic planning across the area. And of course, times are hard, and all services are, and Northern Ireland's in a particularly difficult place because of no government and no executive functioning. So securing commitment for this work does require some capacity and resource, and that's really challenging at this time. But you know, obviously those that are around the table have been very committed to this, and we continue to be. So just finally to acknowledge the partnership. Lisa and I are here today, but this is a collective partnership effort. But also particularly Sinead Malone, who was from the ICP, who helped to co-chair the group and has helped to lead this work. Thank you very much.